we have news today that, that hospitals may well be forced to consider a form of triage whereby patients are graded with a points-based system, and that anyone over 65 will be given a score to decide if they need to go into intensive care, into ICU. And of course, if they're not in ICU and they're treated in the ward, but they're over 65 with coronavirus, then they are likely, unfortunately, not to survive if they're not getting the intensive care they need. Now, the situation is that there will be a clinical frailty scale that doctors and health professionals have been issued with to identify who may not benefit from critical care interventions. So I imagine what that means is that, say, person X is 78 years old, and they're given a scale, they're given a points just for their age to begin with, they're given some points. And I imagine what that means is that the doctors will then make a decision that person X, who's 78 years old and has coronavirus, has a certain number of points which demonstrate that we've decided that even if we put them into ICU, they're unlikely to survive, and that equipment and the bed is also needed by somebody who is 50 years old, who has a longer life ahead of them still, and who's more likely to survive. Those are incredibly difficult choices that doctors and nurses are going to need to make to start prioritising who they treat. So first of all, think of that just from the perspective of how hard those decisions would need to be for the doctors to make them, rating human beings as to who deserves treatment. It must be an incredibly psychologically straining thing to have to do. Any patient over 71 years old will automatically score 4 points just for their age, and likely another 3 for their frailty, taking their total to 7. Once you go over 8 points, you don't get into ICU. In other words, most old patients, by the sheer demands of this is triage, right? Just the demands of having to too many people coming to the hospitals and not having enough beds to treat them. With this points-based system, most patients over 71 years old, if they're frail as well, will be just 1 point away from not being in ICU. So if they have an additional condition, an additional underlying health condition, one imagines that's even more points. They'll go over the magic number, which is 8. And once they're over 8, they won't be let into ICU. So it's very difficult. And one wonders, is there any other way to do this? And it doesn't look like there is if there's too much demand on hospital beds. But imagine you're the family. And imagine, as the family, you are told that your 75-year-old grandfather won't be taken to ICU because they are disqualified due to having a certain number of points on the clinical frailty scale. That can't be a comforting thing to hear. Because, of course, that is in effect, though I caveat this by saying I fully understand why this is being done in a form of triage. The doctors simply don't have enough staff nor beds to treat everybody instantly. But when the listener hears this from a family perspective, how are they not going to hear that this is a death sentence on their grandparents? Now, I say death sentence, that's loaded, because it implies there's another way to do things. I can't see another way to do things, but this incredibly difficult decision of implementing triage, it's what you do in... so triage means this. It means prioritising which patients to treat first. And it's what doctors have to do in field hospitals, in war zones. If a soldier or even a civilian comes into this field hospital, say you're in Basra in Iraq or wherever, one person is bleeding out, right? And their arm, whatever, has been blown off, and the blood is literally, they're bleeding out. And another person has a broken, let's say, a broken leg. In that instance, you have to treat the person who's bleeding out first, and that's a form of prioritisation. It happens in the A&E wards. If anyone goes into accident and emergency, you'll see this. If you say you're in a great deal of pain, like unbearable pain, but you're not bleeding and you don't have a broken bone, then you're likely to wait longer than those who are either immediately bleeding right there or who have a broken bone. And that's where in A&E they implement this form of prioritisation too as well. But you know, if you're in pain and your life's not in jeopardy, then you could still probably get through that night and go home the next day and be relatively okay. Here, we're talking about people that won't get through it. Once they're prioritised, they won't be put into ICU. They've got coronavirus. They're 75 years old. They will be highly likely not to survive the illness. But we're in this situation because some intensive care wards are now approaching capacity, with about 5,000 COVID-19 cases presenting every day. Intensive care wards getting 5,000 COVID-19 cases presenting every day. Imagine that. Imagine you're in a hospital and that's the numbers, the sheer numbers coming in to get treatment. In that situation, when you're faced with that situation, I don't think you have much of an option. But if you're a doctor and you're having to start making these sorts of prioritizations, it must be incredibly straining. We'd love to hear from you as to how you cope making what are quite literally life and death decisions about who gets treated and who doesn't because of the point system. Likewise, if you're somebody who's a family member and you're concerned, we'd like to hear from you as well. Though, again, I caveat, this is not with a view for me to say that the NHS have got this wrong. I genuinely, if you're getting 5,000 patients coming in every day and your beds are at capacity, what else are you meant to do? You don't have the staff, you don't have the beds, you don't have the kit, the equipment to treat everybody. You're faced with a 75-year-old and let's say a 30-year-old, both with coronavirus, but the 75-year-old, again, this is going to sound really callous. You're looking at that 70 as a doctor and you're saying, I've looked at your chart and, on average, everyone with your condition at your age, with these underlying health complications and your added frailty, even without coronavirus, would have survived another 6 months. On average, that's just what the data tells you. This is me giving you a hypothetical example. And then that same doctor looks at that 30-year-old and says, yeah, on average, you've got another 50 years of life left in you. Who are you going to treat? Now, of course, when you look at it in that truly just, stripped down way, in that really just raw way, of course, the 50-year-old is got a longer life ahead of him, hasn't lived for as long, so there are moral reasons to it, and then also the economic reasons, will be more productive for the rest of their life while they're still working. You combine moral and productive reasons there together, and you say, and there are people that rely on that person, and you say, okay, yeah, I think we're going to have to prioritise the 50-year-old over the 75-year-old. But it's a terrible choice to have to make. But that's the choice that doctors are going to have to start making because of capacity just not being there. Do you support patients being prioritised with a points-based system in this way?